right, how are you? I'm good. So we're going to talk about aquablation today. And we're probably talking about this because I did some measurement of your prostate, and your prostate is pretty big. I generally reserve this treatment for patients who have a prostate of at least 85 grams. There are some criteria with the insurance companies, unfortunately, that also include age as a restriction, that you have to be less than 81 years old to be eligible for aquablation. And that is because the trial was done on a population of patients with a maximum age of 80. But there's no real reason why you couldn't do it. I've done it on patients who are older who paid cash, but unfortunately, that's like the only option right now. Hopefully, that will change. It really is good for anybody with a big prostate. And what it does is it's, I think, the first surgical treatment for BPH that actually leverages robotics as in a tool. For cancer, it's been great. My experience as a surgeon has been wonderful with the ability to use the robot for cancer. And so now this technology, as soon as I heard about it, I was very excited about it, that you can, come into the modern era. I do a great TERP. I love TERP. It's a great procedure for patients with a gland of less than 85 grams. Uh, if you get the right training and you do your due diligence in terms of controlling everything, making sure you do a good resection. But it has been something that we've been doing since 1870. And so it's nice to actually have something new. Uh, so the thing about TERP, which there's another video for that if you wanted to watch it, but it's basically where I just go in and start scraping it out. Just do a manual Roto-Rooter. And when your prostate is kind of an average enlargement, that's fine because you kind of know how far out you're going to go in any given direction, and you get a nice resection and you get rid of all of the gland, and there's a low recurrence rate. I mean, basically, what we're looking at the end of the day, what doctors look at, there's a lot of talking about this may work and this might work, and this sounds promising, but at the end of the day, we're looking at results. How do patients do? And if the gland size is, less than 85 grams in a TERP, if it's a well done TERP, the patient does great and they basically are fine for the rest of their life. Generally speaking, it's like a 2 to 5% chance of ever needing anything done with your prostate. But once you get up over 85 grams, being able to just look in and see, okay, I need to go this far in depth in any given direction becomes much more difficult. And so what this technology does is allows us to open up the prostate gland with an ultrasound in place, so we see exactly where the borders of the prostate are. And then we map out the prostate, and I'm going to show a video. And then this thing comes in and does like a pressure wash. It's basically, you probably may have described it to you. There's this technology where, the water jets now they can do like a robot, that the stream is so strong that they plug in what they want and they can actually etch, into metal with this water jet. And that's the technology that they're using here. It's not as strong as the stream as the one that etches into metal because it's soft tissue, but it's basically the same premise. So I have a little video to show you. I'm going to attempt to do this. Share screen. Okay, here we go. All right, so it's like the silent movies. As you can see, I have this on. this screen over here. So I'm looking. So he's introducing the ultrasound probe. Again, you're completely asleep for this. That's a transrectal ultrasound probe. You can see the ultrasound is actually visible on the right screen. There's two screens. The center screen is the actual camera. So once you get the ultrasound in, then you mount this camera / robotic pressure washer device. So it goes in, you're asleep again. And this is all kind of actually not too uncomfortable, even if you're awake. We did a scope in the office, I'm sure. And so this is now mapping out the prostate. You have the ultrasound, then you're going to map out exactly the borders of where you want this water jet to go. You do it in, get all the dimensions. Here's the full mapping here on this is called the sagittal view. So he's just doing the mapping, and I'm the one doing all this. All right, and then see that shaded orange on the right, we'll talk about that later, but basically that situation is what makes it so it does not affect your ejaculate. So the initial data on this was presented as there's a 15% chance that this would affect your ejaculate. Steve Kaplan in Mount Sinai, who's done probably the most of these, just released his data, and he has a 2% chance of affecting your ejaculate. So this is the machine working. So this is the little pressure wash, and bye-bye prostate just washes it away according to how you mapped it. And you can see that the washed away prostate is getting aspirated through the device as well. That little steam that you're seeing is actually the tissue being aspirated. So it washes it away. And on the right, you can see that's exactly what it looks like in real time. That thing's going crazy. And it did one side, now it's going to do the other side. And this is just around the bottom where the ejaculatory duct is. It does these butterfly cuts to preserve the ejaculation. And this is something that I could do, for any size prostate. There is a significant cost. I mean, it costs 3 times as much money, basically. Right, that's it. That's the video. It costs 3 times as much money, and for the result, it's basically the same if your prostate's not big. We can stop that. So that's basically how it works. About the ejaculation piece, if I were to do a TERP, basically all that tissue gets removed, and it's 100% chance that you would have retrograde ejaculation. What that means is basically you have a normal erection, you have an orgasm, but then nothing comes out. Everything goes back into your bladder, and you pee it out later, and it's harmless. But that is something that some men really hate. So again, this technology basically, it was looking like it only happened 15% of the time, but based on Dr. Kaplan's data, it's a lot less. Probably, if you do those butterfly cuts, it's probably less than 5% of the time that you have any ejaculatory dysfunction. So this really should not affect your sexual function in any way, or vast majority of the time. After this procedure, I go in. So after the animation you just saw, I go in and there's bleeding because that doesn't do any cautery. So I have to get the clots out and I have to cauterize the bleeding. And then there's a catheter. So either way, TERP or Aquablation, I manage it the same in terms of the catheter. There's a catheter for 3 days. Almost all Aquablation patients stay overnight. And that's because this tissue kind of oozes a little bit. That there's not a distinct thing to cauterize. It's just the whole thing is kind of oozy. And so the urine is a little bit too red for you to go home the first night. So we have to have you stay, and we wash the fluid through the bladder to make sure there's no clots that form, because what we don't want to happen is we don't want a clot to form and then block the catheter, and now it's a disaster, right? So we keep you overnight, run that fluid. Everybody goes home the next day. The next day, the urine is relatively clear. It's like a pink. It's like a salmon pink. It's a unique color for this procedure that it ends up looking. And then we take the catheter out for 3 days, and then you'll have immediately a better stream. Now, the urine is going to be looking red for a while, for like 3 to 4 weeks. And that's because it's like food coloring, just a little bit of it will taint the entire urine red. In addition, it may not be even active bleeding because you go through, you saw what happens. So imagine now there's kind of like a scab that's there, or a wound, surgical wound. And when urine passes over that, it kind of leaches that wound, that material that's not necessarily blood, active bleeding. It's like blood product, but it's not active bleeding, but it's leaching into the urine and discoloring it. So it's going to look red. You may even see some small clots. From time to time, that scab will fall off. Usually it's 10 to 14 days where there's like a bloody show almost. And there's some material that passes through. You may see, oh my gosh, and then that should go away, within a day or so. But you may see intermittent bleeding for 4 to 6 weeks after this procedure, basically. The chance of being admitted to the hospital for significant bleeding is quite low, unless you're on a blood thinner like Eliquis or Plavix. That does elevate your risk. So if you're not on any significant blood thinner, like a baby aspirin's fine, okay. But if you're on like a hardcore blood thinner, like Brilinta or something, then you're talking about maybe a 10 to 15% chance of being admitted to the hospital at some point in within 30 days for bleeding. If you're not on any of those medicines, it's like a 2% chance of being admitted to the hospital. And if that were to happen, you'd come in to like Longwood or whatever, and they would call me and I would take care of it. And, it would not be fun, but it would get fixed. Okay. It would get fixed. 2% risk of significant infection. And that's basically the risk as far as recurrence rate. So the big thing is that this improves the recurrence rate, and it's looking like about a 2% chance of ever needing anything done with your prostate with regards to BPH in the future, which is benign prostatic hyperplasia. This again does not treat cancer. This is simply for relieving the obstruction. So that's basically it. Just make sure to go through all your pre-op instructions and clearances and everything like that. If you have any questions, just call, and I will see you later.